So most of you guys know me, or at least know my name, Scott Kranklow, with all the consonants in my last name. But I'm specifically heart rhythm, so I am cardiology, but I just work with Dr. Cataldo in electrophysiology. So I don't see consults for chest pain. I'll see consults for EKG abnormalities, atrial fibrillation, patients with pacemakers, defibrillators, and then kind of the procedural end of our specialty is ablations. And so I'll be kind of going through just some of the things that come up a lot in terms of questions about pacemakers, defibrillators, what they do, what their limitations are, and then also talk about the ablation procedures. And so that's kind of what the bread and butter of our specialty is, and it's something that is a kind of growing specialty, and is something that isn't really covered in standard education because it's always changing. And so kind of going through what we do in ablations and what some of the considerations we have for our patients depending on what type of ablation is done, because every procedure is a little bit different. So EP basically, as I said, we're just focused on cardiac rhythm disturbances. So it's a subspecialty of cardiology. An electrophysiologist like Dr. Cataldo went through a kind of a internal medicine residency, and then a cardiology fellowship, and then a kind of EP fellowship on top of that. So our treatments are device-based, but then also ablation based. So kind of just an overview, and a lot of this is in here just so that there's reference when I send the slides out to read through, because things are pretty wordy. But either way, when we're making a diagnosis, most everything we do is based on objective data. And so there's not a lot of subjective symptoms that will tell me exactly what's going on with the patient. A patient who describes symptoms of palpitations or tachycardia could have any number of things. And so we do a lot of things to gain that objective information. So in the hospital, that's telemetry, EKGs, but then as an outpatient, that's where we do ambulatory monitors like event monitors, loop recorders, and then also pacemakers and defibrillators have monitoring capabilities as well. So a lot of things that we use to make our diagnosis are these, a lot of the tools that we have available in the hospital. One thing I will go over just briefly, because there ends up being a lot of questions about these, is our outpatient monitors. There's really three different types. We have a Holter monitor. A Holter monitor, by definition, is a beat-to-beat cardiac recording. So what it does is it saves all of the heartbeats for a set amount of time, whether it be 24, 48, or sometimes up to a week's worth of data. That information is all downloaded and then sent to a company that interprets these. They go through and look at things that are automatically captured. They provide a report to us, and then we go through and look for that. So Holter monitors are really good when we're trying to assess the severity of something we already know is going on, something like atrial fibrillation or frequency of PVCs, because it gives us that beat to beat. But it's limited when we're trying to address paroxysmal symptoms. So if a patient has tachycardia once every 2 or 3 weeks, we're not going to start with a Holter monitor because we're unlikely to capture it. So the next category is what we call an event monitor. An event monitor is still it's an external worn monitor, but what it does is it just saves certain things. So if it notices tachycardia, it notices significant bradycardia, it'll record a strip and it'll ask the patient what kind of symptoms they feel. And then also patients can automatically trigger as well. So I felt something, and it'll save a set of that, and then we'll review it afterwards. A loop recorder is an actual implanted cardiac monitor. It's called a loop recorder because it basically records and deletes on a loop. So it'll record given amount of time, 10 minutes. If it detects any abnormalities there, it will save it. If not, it deletes it and then saves space to record again. The loop recorders that we have now communicate with a smartphone application or a dedicated smartphone that upload those. And so those are good for patients that have very infrequent symptoms. So we put an event monitor on them. It's negative for 30 days. We still have a suspicion that they might be having atrial fibrillation. We'll put a loop recorder in. When do we need to interact with the interventional cardiologist is anytime we see rhythms that could be related to structural cardiac disease. So if a patient's having sustained ventricular tachycardia or even kind of non-sustained VT, we'll often ask the interventional cardiologist to rule out an ischemic source. And so that would be a stress test or a heart catheterization, because we don't want to assume that something is all electrical and not related to structural abnormalities without kind of ruling that out first. And so that's a lot of times when we'll have interventional cardiology do some kind of an ischemic evaluation. So that's kind of just the crash course of what I do, what Dr. Cataldo does. Any questions in terms of how we interact, how we interface with patients and how we interface with other specialties? All right, yeah, it's kind of just our standard practice with the EP service. The way the EP service works right now is I'm in the hospital Monday through Thursday basically from 7 until noon, and I'm in clinic in the afternoons Monday through Thursday, and then I'm here 2 Fridays a month. And so my schedule is kind of all over the place, but after 5 o'clock, any call should go to either Dr. Cataldo or the on-call cardiologist. But during the day, if I answer the phone, I'm available. So, so the kind of big thing that we do a lot of are pacemakers. We're not the only service that does pacemakers. The interventional cardiologist, Dr. Winkler, will do pacemakers. Cardiac surgeons and vascular surgeons will also implant pacemakers. But pacemaker is basically just a device that's able to treat slow heartbeats. It can't slow anything down. It's just there to basically watch and see if the heart is going slow and deliver the imperceivable pacing impulses. The way we decide on what kind of a pacemaker they need, whether it be a single chamber in the ventricle, a atrial pacemaker, or a biventricular pacemaker, is all based on what kind of rhythm disturbance we're treating. So a patient who has sinus node dysfunction, so their resting heart rate is in the 30s or 40s, we need them to atrial pace because we want to pace in the atrium and let the rest of the heart respond through the AV node and then the ventricles. If a patient has AV block, so they're having issues where there's signals aren't communicating between the atria and the ventricles, well then they would need the ability to ventricular pace. And so if the pacemaker senses that there's been an atrial action potential and the ventricle hasn't responded in a set amount of time, 200 milliseconds, then it will pace in the right ventricle. So with the pacemakers, the leads that we put in are meant to be there permanently, and the newer leads I think probably are in that order where as long as everything goes well, they're probably lifelong. The actual generator though, the pacemaker, has a longevity in the order of 5 to 15 years depending on how often it's requiring to pace. When we need to replace it, it's a simple surgery. We just open up the pocket, take the old device out, and then attach the new one. Our practice is to keep the patients overnight after a generator replacement, and our patients will typically follow up in the office 1 to 2 times per year on a minimum based on what's going on with their pacemaker. And then we will also have the ability to remotely communicate with the pacemakers through the bedside monitor. So we'll get kind of regular downloads every 3 months to just ensure that everything's working fine with the pacemaker. It'll also send us kind of alert red flags. And so even our patients that are pretty remote, we know if there's an issue with a lead dislodgement or battery depletion. But Mike Skaggs will kind of go through a lot of this as well. MRIs can be performed on new systems. It's not routinely being done at this hospital yet. So again, we select device types based on some patient characteristics, and we will implant pacemakers in patients with atrial fibrillation, but it's not to cure the atrial fibrillation. All it is to make sure it's not going too slow. So we have patients with atrial fibrillation with tachybrady, so we try and rate control them, but then all of a sudden they have rates that are in the 20s, 30s, or post-conversion pauses. They'll need that demand pacing to prevent excessive bradycardia. Biventricular pacemakers are basically pacemakers that have the ability to pace the left ventricle as well. I'll talk a little bit more about that. But that's for patients who have underlying left ventricular dysfunction, because if you pace only on one side of the heart, you can develop a pacemaker cardiomyopathy, which will actually worsen the left ventricular ejection fraction, because now you have this kind of wide, slow, when you look at a paced complex, it's usually rather wide. And so patients who have structural heart disease typically don't do well if they're pacing all the time in the ventricle. So that's sometimes why we get an echo on all of our pacemaker implantations. So some of the nursing considerations, and again, this is more focused on Dr. Cataldo's practice. Doesn't apply completely to how the surgeons, their recommendations, or Dr. Winkler, but this is kind of our overview. And so if you have any questions, and it's not our patient, just ask Mackenzie or the cardiologist that's implanting. So before we implant the devices, we always have the patient's NPO. We don't always use anesthesia. That's just going to be dependent on patient characteristics. Sometimes they're just done with sedation and local anesthetic. We'll typically stop any kind of full anticoagulation. So Eliquis, Xarelto, Pradaxa, warfarin. We'll have them stop those for about 2 days before, especially if they're just using for prevention of stroke risk reduction. I'm okay with the patient being off of it for 48 hours to allow for a pacemaker implantation. Antiplatelets will have to be continued. If a patient's within 1 year post PCI, we don't interrupt dual antiplatelet therapy for implants. It just means there's going to be a greater risk of hematoma, and that's something we'll discuss with the patients. We'll always keep our patients overnight. We do a chest X-ray following the procedure, and we'll have that device check the following morning. If everything looks good, electrically, when Mike or David come and look at the device, then they're good to go. Our recommendation is to have the patients minimize left arm or whatever side we implanted on, most often left, for about 6 weeks following the procedure. The reason being is we really want to minimize the risk of dislodgement. So little motions, like eating, reading, are fine. It's really the big motions that are going to pull on the pectoralis. That's what can cause lead dislodgement. And so our recommendation is the 6 weeks. We don't like our patients to wear slings as an outpatient though, because yes, that'll probably put the dislodgement risk very, very low, but then they'll end up with long-term shoulder and elbow, which can freeze up if they're in a sling for that long. Primary complications after the procedure would be development of a hematoma. Most of our patients, we routinely put pressure dressings on if they're pretty bleedy during the procedure, especially if they're on antiplatelets. And so if the patient seems like their hematoma is getting larger, what we advise is to hold direct pressure over the pocket and the incision, and apply a kind of a new bulky dressing on top of that to help get some hemostasis. Pneumothorax is pretty rare with these procedures, but again, it's something that's good to just watch these patients if they're having worsening dyspnea, hypoxemia. Take a look at the X-ray report and see if they maybe had a pneumothorax that a radiologist saw. Once we put a pacemaker in, we don't always expect to see pacer spikes overnight. And again, if the patient just needs demand pacing, they might not be pacing at all while they're in the hospital. And again, we can't slow the heart rate down. So if the rate's above 60, the pacemaker's doing its job. There is, with these devices, and Mike will talk about this as well, is after the implant, there's this automatic testing, which is this kind of run of pacing, usually at a rate around 90 or 100. And what that is it's the device checking to see what voltage it requires for capture. And so you'll see this and it'll look like a slow ventricular tachycardia, but what it is it's just automatic testing on the device. So if it's wide but not fast, it's likely coming from the device. It doesn't always show pacer spikes in that case. So then the kind of next thing from a pacemaker is our defibrillators. So defibrillator has all the same capabilities in terms of pacing the heart, but it also has the ability to terminate tachycardias. And so the indications for putting an ICD in is a patient who we have kind of two main categories. We have primary prevention and we have secondary prevention. So primary prevention is putting an ICD in because the patient is at risk of developing a life-threatening ventricular arrhythmia, so ventricular tachycardia, ventricular fibrillation. We define that risk. One category is that they have persistent LV dysfunction. So if their left ventricular ejection fraction is less than 35% and it hasn't improved on optimal medical therapy or post-revascularization, then the indication is for putting a primary prevention device in, because their risk of ventricular arrhythmias is considered higher than the risks of implanting the device. The other category for putting a defibrillator in is for secondary prevention. So secondary prevention is a patient who's had sustained ventricular tachycardia, has had an out-of-hospital cardiac arrest related to a ventricular arrhythmia, and they've been resuscitated. So in that case, you put it in because you don't want, they're obviously at risk. You don't want it to happen again. And these devices have a few different methods for trying to terminate these ventricular arrhythmias. And so the first thing it'll do, if it senses the patient's in ventricular tachycardia, is it'll do what's called overdrive pacing. What that is it figures out how long that cycle is, and then it'll pace even faster. And sometimes by pacing faster, it's able to interrupt that electrical short circuit and then get the heart back into rhythm. And so what it will do is it'll detect that there's this ventricular tachycardia, deliver these paces while the capacitors in the device are charging up to deliver a shock if the pacing is ineffective. And so sometimes we'll see, a patient will have, a wide complex tachycardia, and then you'll see a faster, wider complex or a different looking tachycardia on tele, and then it'll break. And that's what ATP looks like. And I think Mike might have some strips that he's going to bring in. And these devices, again, have all the same function as a pacemaker. They save cardiac information or rhythm information. They communicate remotely. The battery life tends to be about the same on them. We follow these patients usually a bit closer because they typically have more medical comorbidities. So again, we have the different types, and I'll talk about the especially the CRT, and so that's our the biventricular devices and what we need to look at there. The concerns with these patients in terms of what we don't want them to do is the main thing I tell them is not to arc weld or do any kind of welding that's attached to a generator. The reason being is that arc welding, you're acting as part of the ground, and so there's electricity going through the device. What it can do is trick the device, make it think that someone's in ventricular fibrillation, and then inappropriately deliver a shock to them. So I usually advise that patients don't do that. But otherwise, being around microwaves, all that stuff is completely fine now. Patients can fly, travel, all of that. So with the cardiac resynchronization, again, this is something that's available in pacemakers, but also defibrillators. And this is an effort to have as narrow as possible pacing impulse as you can get. So again, the normal conduction system goes in the septum between the right ventricle and the left ventricle before going to the bundle branches. And so you have a nice, quick cardiac contraction. And that's the way to optimize your cardiac output. But if a patient has a left bundle branch block, what happens is you have your left side and then your right side, you're kind of going out of synchrony. And so the heart, what it does in that case is it actually moves a little bit inside of the chest with each heartbeat, because it's not, you're pushing one way and then pushing the other way. And so a patient who has a cardiomyopathy, so their left ventricular function is already decreased, and they have a slow contraction, by adding a wire to the left ventricle, we can speed up that contraction, and sometimes that'll improve their cardiac output. So the way that we do this is we don't want to put a wire inside of the left ventricle, because if there's a wire inside of there, then you have very high thromboembolic risk, because it's going, the outlet is the aorta into the carotids. And so the way that we can get around that is by implanting a lead inside of the coronary sinus. And so we put the normal wires in the right ventricle, the right atrium, and that's all through the subclavian. But then also from the right atrium, we have access to the coronary sinus. The coronary sinus is where arterial blood drains back into the right side of the heart before going to the lungs. And so if we access that coronary sinus, we can use the vessels on the outside of the heart to place a lead out into the left ventricle. And that can be done most of the time. In some patients, their coronary sinus anatomy is either too small, too tortuous, or we aren't able to access where the coronary sinus enters the heart, and we're unable to place that lead on the outside of the heart. If that's the case, we'd have the surgeons basically do a mini thoracotomy and sew the lead onto the outside of the heart, tunnel it up to the device. We try and get them in as much as we can, but again, there's some patients you just can't place that lead. So the thing that can be a problem, though, by implanting a lead on the outside of the heart instead of the inside of the heart, is that the phrenic nerve, which innervates the diaphragm, goes over the outside surface of the left ventricle. And so when you have pacing that's happening on the outside of the heart, if the phrenic nerve is in that vector, what it can do is pace the heart, but also pace the diaphragm. And so what patients will experience with that is this kind of sense of hiccuping, and you can actually feel it if they're having stimulation of their chest bumping at the rate of the pacemaker. If that happens, usually we can program around it by changing where the pacing actually happens on that lead and get around that. But again, it's something that we just have to watch with our patients, and it's not always going to happen just because they don't have it when they're laying flat. They might have it when they lay on one side or in different positions. And so that's something to be aware of. If you notice a patient's having this, they say they're having hiccups, they feel like they're having chest pain, or they feel like I feel like my heart's pacing. If they're having that, give us a call, and then we'll have the representatives come in there and try and reprogram it. During implantation, we always check for that to make sure that we have at least one vector that doesn't have stimulation. But again, that's when the patient's in a completely supine position. We don't know what it's going to be like when they turn on their side. So patients with larger body habitus tend to have more problems with stimulation. And that's what this is shown here. So we have the phrenic nerve outside of here. This pacing can interfere with that, and so we just need to program around that. Very rarely would we basically have to disable this lead because we can't find a vector that works. Because in some cases, this lead can actually back out a little bit and get closer to the nerve, and we don't have an amenable vector. So some of the nursing considerations that are a little bit more specific to the ICDs. Again, these patients tend to be a little bit sicker than your average patient if they qualify for an ICD. Not all the time, but mostly. And so we almost always do these under anesthesia, especially if we're implanting that lead onto the left side of the heart. Same limitations in terms of arm motion. With these, we have probably a greater risk of hematoma development. The reason being a lot of these patients are on antiplatelet therapy, and the device is also probably about 3 times the volume of a pacemaker. And again, has all the same pacing. We wouldn't expect, or the device won't do anything about PVCs. So if a patient's having PVCs with an ICD, that's normal. It's not going to do anything about it. Brief episodes of non-sustained VT, 5 to 10 complexes, it's not going to do anything about either. So, any questions device-wise? I know Mike's been and David have been really helpful about going around and kind of going through that, but I guess some of the night people maybe don't see him as often. So medication-wise too, one question that we often get when our patients come back is, their metformin. So with these procedures, we just use a small amount of contrast for a subclavian venogram. So we'll inject dye through the IV on the side that they're getting the device on. So that's why we always want to make sure patients have a left-sided IV before they go to the cath lab. Unless we're doing a right-side implant, then we'll ask for a right. But the reason being is we do a contrast under live fluoroscopy to make sure that they have a patent subclavian vein that will allow us to put the leads in. But again, the amount of contrast that's used with that is very minimal. We do use contrast for the left ventricular lead placement as we're looking at the anatomy of the coronary sinus. And so that those patients kind of is a case by case, depending on how much we use. I know Dr. Winkler tends to use a lot more contrast in his cases. The reason being is he's an interventional cardiologist. He's used to using contrast to identify the coronary sinus, whereas in our case, Dr. Cataldo accesses the coronary sinus every day with his ablations, and so he has different techniques for getting in there, but we still do use some contrast. Again, antiplatelets are, depending on when their intervention was. The full anticoagulants, if it's for paroxysmal AFib, typically we'll restart those after about 3 or 4 days to minimize the development of a pocket hematoma. Antibiotics, we give, if they're not allergic, we'll give Ancef immediately prior to incision, and then we'll also give an IV dose several hours following. The only time we'll send a patient home on oral antibiotics is if we're putting kind of replacing the device, and so if there's already an existing pocket. So if we're upgrading their device, we're doing a generator replacement, those have a greater risk of infection because the pocket that forms around the device is actually ends up being pretty avascular. It's almost like scar tissue underneath the skin. So there's poor blood flow in and out, which means there's poor infection control in the body. So those patients are at greater risk. So we'll put them on a course of usually Keflex following the procedure to minimize infection risk. But new implants, we almost never use antibiotics as an outpatient. So the other procedure that we do a fair amount of are our TE cardioversions. Sheena's well aware of these. So again, a cardioversion is most often done to terminate atrial fibrillation, and it's used in a different sense depending on kind of what specialty you're in. In electrophysiology and Dr. Cataldo's practices, we'll cardiovert a patient if they're in atrial fibrillation, and we want to try and get them in a normal rhythm and keep them in normal rhythm. So our practice is to not cardiovert a patient unless we have some kind of medication that we're going to put them on to help keep them in rhythm. Because just cardioverting a patient and putting them on just a rate control medicine, metoprolol diltiazem, it's likely it's going to come back at some point in time, usually pretty quickly. So what we'll always do is have an antiarrhythmic selected, and there's a lot of patient considerations that we take into account when we select what they're going to use. And we almost always will do a transesophageal echocardiogram prior to our cardioversion. And so the utility of a transesophageal echo is we want to ensure that the patient hasn't developed a thrombus inside of their left atrial appendage. And so the left atrial appendage is just a vestigial pouch that comes off of the left atrium that has poor blood flow in and out. And especially when the heart's in atrial fibrillation, there's almost absent blood flow in and out. And so what can happen is if a patient's non-anticoagulated, a blood clot can form there. And even some patients who are anticoagulated can still develop a blood clot inside of their heart. And so our practice is we'll pretty much always do a TEE because we've seen enough patients that have developed a thrombus despite saying that they've been completely compliant, they've taken their anticoagulant every 12 hours for the last 3 months. We want to just ensure because we don't want to cardiovert and give a stroke. That being said, it still is, there still are standards of practice that allow for cardioversions without the assistance of a TEE. But in our specialty, we tend to go with the TEE unless there's certain patient considerations. The reason it has to be a TEE versus a transthoracic echocardiogram is just based on the way the heart is oriented in the chest. And so the left atrium is actually very posterior and is right up against the esophagus. And so by doing a transthoracic echocardiogram, we're not going to get a good visualization of that structure. So that's why it has to be from the esophagus because we're, again, right there. And so what a left atrial appendage looks like from a transesophageal echo is kind of this pouch here. In this case shows some thrombus in there. So if we see that there's a thrombus hanging out inside of the heart, what we'll do is probably change them to a different anticoagulant. So if they've been on Eliquis or Xarelto, which have the same mechanism, they're factor Xa inhibitors, we might change them to Pradaxa, which is a direct thrombin inhibitor. And sometimes just by making that change is enough to allow this to not develop any further. And then we can bring them back for a cardioversion down the road. And medication-wise, we'll usually just hold their rate control medicine. So if they're on diltiazem, metoprolol, oral before it, we don't want to have them loaded up on these rate control and then cardiovert them and then see what their sinus node does and have them be really slow. So typically I'll hold the orals the morning of. If they're on IV diltiazem, usually we just stop that just prior to the procedure, and that usually clears fast enough that it's not as big of an issue. And then we always want to continue their anticoagulation the morning of the procedure. Again, we want their blood to be as thin as possible in preparation for the cardioversion. And the practice, kind of standard practice, is anytime you cardiovert somebody, you need to keep them therapeutically anticoagulated for at least 30 days following procedure, regardless of what their CHA2DS2-VASc score is. Because even though you've restored sinus rhythm, it takes sometimes up to a month for the atrium to actually gain kind of full motor function back and allow adequate blood flow in and out of the atrial appendage. Any questions on that stuff? Obviously, we do a lot of these. Yeah, go ahead.
Can you just explain the CHA2DS2-VASc?
Yeah. So CHA2DS2-VASc scoring is a modified. It used to be the CHAD score, and then now it's the CHA2DS2-VASc score. And what this is it's a kind of risk calculator that we use to guide if a patient needs to be anticoagulated. And so there are multiple things that are part of it, and the categories are age. So patients who are between 65 and 74 get a point. 74 and older get 2 points. Gender, female gender gets a point. Male gender does not. And the reason being is female hormones tend to be more put you at a higher risk of developing blood clots. And then the other factors are if they have a history of vascular disease, so if they have known coronary disease, they've had an MI, that gives them a point. If they have congestive heart failure, that gives them a point. If they have a history of a CVA or a TIA, then they get 2 points for that. Because clearly if someone's had a TIA as a result of AFib, then that's a pretty high risk. And then if they have hypertension or diabetes, are each worth a point. So basically we kind of take all these patient considerations into account and decide, do they need to be on a blood thinner? The threshold for being on blood thinner is a CHA2DS2-VASc score of 2 or greater. And so when you start thinking about our patients, almost all of our patients have that CHA2DS2-VASc score of 2 or greater. What that means with a CHAD score of 2 is that your risk of stroke is greater than your relative risk of being on a blood thinner. So the risk in a given year of being on being therapeutically anticoagulated and having a bad outcome is in the order of 1 to 2%. And a CHA2DS2-VASc score of 2, your risk of having a TIA or stroke or any kind of other thromboembolic event is probably in the order of 3 or 4%. And so in that case, we'd say, okay, well, they're at a greater risk of a stroke than they are of having a bleed. I'd rather have them, that risk of a bleed over the. So, and again, most of our patients end up being, anticoagulated. Unfortunately, the newer agents are a lot safer than the warfarin, partly because they maintain a stable pharmacologic profile, and we don't see nearly the amount of, bleeds as we did when patients were routinely on warfarin. We almost never prescribe warfarin. And yeah, they're developing reversal agents for the newer drugs, Xarelto and Eliquis, but the study has shown that the reversal agents for those are no more effective than giving like FFP. And so we're not routinely using those, nor do we have to use them that often in comparison to warfarin. Any other questions on that end? Okay, so now I'll kind of go into what actually happens when we're down in the EP lab. So what is an ablation? What are we actually doing in there, and what are our capabilities in terms of an ablation? So the first thing that we can do is kind of our baseline testing. So if we have a patient who we haven't seen anything abnormal on cardiac monitoring, but we're suspect some kind of cardiac rhythm disturbance, what we can do is a procedure called EP testing. This is what we do is getting inside of the heart with multiple electrode tip catheters that are able to show us conduction from areas of the heart to another. So a 12 lead kind of gives us surface clues of that, but having the catheters inside the heart, we can actually identify a structure and measure conduction time between different areas. What we can also do in these procedures is do pacing maneuvers to try and induce certain arrhythmias. So sometimes by rapidly pacing the heart, we can get that to show that a patient has unstable ventricular tachycardia in a controlled setting, or evaluate for the need for a pacemaker by looking at conduction time. And so typically that's kind of the baseline with it. All of our patients will do certain conduction time measurements as a baseline before any ablation that we would do. So once we've done the EP testing, that's where we can start going into, okay, is this an arrhythmia that we can actually ablate? So once we've identified that there's a kind of abnormal conduction system in the heart, and we want to address it, what we'll do is, instead of just mapping with these catheters, we can actually deliver radiofrequency burns to areas of the heart to block electrical conduction or get rid of some of these extra pathways. So the first kind of ablation, and probably the most common, would be a SVT ablation. So SVT is arrhythmias that are originating from the atria and then resulting in the ventricles to go fast as well. And so a lot of times we've already kind of made a diagnosis of what we expect it's going to be before taking them in. And again, it's going to be patient dependent whether we're going to use sedation or anesthesia. And so the most common things that we treat with this would be like AV nodal reentrant tachycardia. And I think I have a slide there that I'll go over with that. But again, sometimes we're looking for, is there an extra pathway that we can terminate and prevent a short circuit somewhere in the heart? Or in the case of WPW. So WPW is when a patient has a accessory pathway that conducts faster than the normal system, which is why we see that slurred upslope on the EKG. But what can happen is that extra pathway allows for conduction outside of the AV node backwards and puts patients into a short circuit that causes the sustained tachycardia. So in that case, we want to figure out where that shortcut is. And usually that happens in development. And so as the heart's developing, there's basically tissue that is either atrial or ventricular that's going through the kind of valve apparatus, and that allows for conduction outside of the AV node. Sometimes with these ablations too, we'll see what's called like focal tachycardia. So this would be an area of the heart that's causing its own spontaneous depolarization and causing the heart to race. And so what we do with that, and that's what we call atrial tachycardia, which is kind of this catch-all for rhythms that are coming that aren't a short circuit, they're not atrial fibrillation, it's just an irritable electrical area of the heart. The same thing we see when patients have PACs, that's an atrial tachycardia focus. And so in that case, you can identify it, make some burns in that area, and hopefully prevent it from coming back. Most often they're on the right side, sometimes they're on the left side, and I'll talk about what we do in that case. Here, some of the times these areas where they arise are too close to an important structure. So if there's an atrial tachycardia arising from near the sinus node, near the AV node, we don't want to make ablations there because then we're basically treating something that's benign and causing conduction system disturbance, which may require a pacemaker. So sometimes we'll bring a patient in and we can't safely do an ablation for it. That happens maybe 1 in 20 or 30 times. So what it kind of looks like when we're doing our procedures is this is kind of the map that's created during the ablation. And so these catheters with all the electrical tips are able to kind of measure distance between patches that are on the chest and the back with magnetic but also impedance. And so by kind of tracing the inside of the heart with these catheters, you get a kind of 3D picture of what the inside of their atria looks like. And then once that's established, we have all these different kind of continuous tracings. What these represent are different catheters in the heart. And so that will give us clues to what kind of rhythm it is. What we can also do is watch electrical conduction propagate through the heart in these views as well. So we capture something and then we see here's where it was earliest and here's how it travels through the heart. And so it gives a lot of clues to where to go after. So in this case, what we're able to do is identify that this is a kind of irritable focus in the heart, and we can tell that this is trying to go faster than the rest of the heart because we have these blue lines here represent the atria contracting. So the atria right now is going at about 4 or 5 times the rate of the ventricles. Anyway, not too important to get too involved in that, but that's kind of what we see. And I don't know. Looks like the video doesn't want to play. But yeah, and so this basically is the ablation catheter is making burns here until we see this cycle terminate. So, ABNRT, again, is something that's pretty common and is, in the scheme of things, a pretty simple ablation from our end. What AV nodal reentrant tachycardia is it's the result of, normally speaking, we have electrical conduction starting in the sinus node, traveling through the AV node to the bundle branches and causing the ventricular contraction. But what can happen is about 20 or 30% of people have dual conduction pathways at their AV node. One is a fast conduction pathway, and one's a slow conduction pathway. And normally speaking, that's fine because it preferentially goes down the fast conduction pathway. But if you have these dual pathways, what can happen is if you get an extra heartbeat, whether it be a PVC or a PAC at exactly the right time, then it starts conduction in the slow pathway. And what that does is you have this backwards, forwards conduction causing the heart to go very fast, usually at a rate of about 150 to 170. These ones are almost always terminated by adenosine. So by giving adenosine, you're terminating conduction at the level of the AV node, and then what that does is it terminates that short circuit, and then their sinus, slow pathway, ventricle, or fast pathway, ventricle conduction system then takes over. So in this case, what our role is okay, can we see these two pathways, and let's get rid of this slow one, because it doesn't need to be there, and it's also predisposing this patient to tachycardia. And so these ablations probably have efficacy probably in the order of 95% of patients who go for a SVT ablation won't have recurrences of AVNRT because we're only making a series of burns in that area, whereas an atrial fibrillation ablation, which we'll talk about, has multiple ablations in multiple areas of the heart, and so there's inherent difficulties in completely terminating it. So another ablation that we're doing on a pretty regular basis would be our AV node ablations. And so an AV node ablation, in the scheme of things, is actually a very simple ablation. We don't even have to use the electrical mapping because we can identify where the AV node is by just using the intracardiac electrograms. So patients that we decide to do an AV node ablation in are patients who have atrial fibrillation that we've made multiple attempts to try and restore rhythm. So we've done atrial fibrillation ablations on them. We've had them on multiple antiarrhythmic medications, and no matter what we have them on, they keep going back into AFib. And when they go into AFib, they go fast. And so when a patient's in persistent atrial fibrillation, then the next thing is, okay, can we at least slow down how fast the ventricles go? Because that's where patients tend to have the symptoms from. And so if we slow down the ventricles with rate control medications. We'll have them on metoprolol, diltiazem, sometimes digoxin, and either the patient is having excessive hypotension, that means their heart's still going fast, we can't give them any more rate control medication safely, well then we'll say, okay, can we just mechanically control the ventricles? And the way we do that is by electrically disconnecting the atrial fibrillation from the ventricles. So the atrial fibrillation is still happening, but that electrical conduction isn't going through to the ventricles. And the only time we can safely do this is if a patient already has a pacemaker there, because we're eliminating any way for the atria to communicate with the ventricles. So our practice for doing this, if we've decided a patient needs an AV node ablation, if they already have a pacemaker or a defibrillator in place that has the ability to pace in the right ventricle, then we can just do the AV node ablation. But the thing that we have to look out for in these patients is, are we going to worsen their left ventricular function by pacing only in the right ventricle? So if they have reduced ejection fraction, then we'll add a wire to their pacemaker or defibrillator before doing that ablation. And that'll allow for kind of that biventricular pacing all of the time. We won't do the AV node ablation and a pacemaker implantation at the same time. The reason being, we have a fresh pacemaker in, and we ablate their AV node, they move their arm, they dislodge the lead, now they're in complete heart block. And hopefully they have some kind of a junctional escape, but we want the lead to be well established before we go ahead and do the AV node ablation. When we do these ablations, we'll typically leave the device set at a rate of 90 overnight, and so the patient will just be pacing this flat line at 90. Mike or David will come in the morning, check, make sure everything is, if they're still pacemaker dependent, then drop the rate down to 80. We see them as an outpatient and then drop it down either to 70 or 60, depending on the patient. But this is kind of our last ditch for atrial fibrillation. If we aren't able to treat the rhythm, we aren't able to control them with medications, then we'll do the AV node ablation. So typically these patients are usually much older, but in some cases we've had patients who are younger who just have such refractory atrial fibrillation. This is the direction that we have to go in. But again, it doesn't do anything about the atrial fibrillation, so they still have to remain anticoagulated because they're always going to be in AFib. So another type of ablation that we do on a frequent basis would be our atrial flutter ablations. And so atrial flutter, or the typical atrial flutter, is a short circuit that travels around the tricuspid valve in the between the right and the left, right atrium and right ventricle. And that conduction pathway causes the atria to go at a rate 3 or 4 times as fast as the ventricles. And when it's typical atrial flutter, what we'll see is that classic sawtooth pattern on a 12-lead EKG. And so you'll see that very regular kind of sawtooth appearance. If the EKG says it's atrial flutter, it doesn't always mean it's atrial flutter. There's a lot of atrial flutters that can come from other areas of the heart that don't have that appearance, and they have a different treatment for it. But if it just looks like typical atrial flutter, we can go in and do an ablation in the right atrium to kind of electrically disconnect that short circuit. So we make a burn between the valve and the vena cava, and what that does is it provides a line of conduction block. And so the circuit can't travel all the way around the valve without getting blocked on our line of ablation. And so if it's just atrial flutter, we can be very effective in preventing recurrences of that because, again, we're making a series of electrical burns between 2 structures, and we're just trying to eliminate a short circuit. But in these patients, we also want to see, have they had atrial fibrillation in the past? Because atrial fibrillation and atrial flutter tend to run together. So what typical atrial flutter looks like, in our mapping, this is kind of using this color mapping, so we're looking at where is the earliest site of activation, and then going slower, so we can see that it's this, in this case, clockwise conduction around the tricuspid valve. And but the video basically just shows termination on there, and all these little red dots here, these are all of the points of ablation. So we know we're done with the procedure when the circuit terminates, but also when we see that by pacing right here, the cycle has to go all the way around this conduction block before getting to the other side of the line. So another type of ablation that we're doing, probably not as frequent, but is something that's certainly in our catalog of procedures, and really in the scheme of things is probably on the lower end of complexity, depending on exactly what it is idiopathic ventricular tachycardia. So idiopathic ventricular tachycardia is, by definition, sustained monomorphic ventricular tachycardia that's not in this setting of structural heart disease. And so we don't know exactly why it's happening, but it can be problematic for the patients. We won't call it idiopathic until a patient's had an echocardiogram that shows preserved LV function. We know that they don't have a history of coronary disease or PCI. We've either done stress testing on them or a heart catheterization to ensure, okay, this patient is not having ischemic ventricular tachycardia. So basically what it is, it's an area of the heart that's in the ventricles, kind of like an atrial tachycardia, that's producing its own rapid depolarizations causing the ventricles to race. We see that as kind of a wide complex tachycardia. The most common places it comes from is the right ventricular outflow tract, and those have kind of characteristic findings on the EKG. So that's why Dr. Cataldo always says if we need to see the EKG, or do we have a 12 lead of this, because by looking at all the leads we can have a pretty good idea of where it's arising from and what the ablation would entail. So again, if it's in the right ventricle, the ablation is kind of on the less complex end, because when we do our ablations, we go in through the femoral veins. The femoral veins then take us to the inferior vena cava, and that goes right into the right atrium. In the right atrium, you can pass the catheter down and then draw a map of the right ventricle and identify where these PVCs are coming from, and then electrically terminate them with our radiofrequency burns. If it's in the left side, so you can have ones that come from the left ventricular outflow tract or the mitral valve annulus, in that case, instead of going up the aorta, what we would do is go into the right atrium and do this transeptal puncture, which I'll talk about with the atrial fibrillation ablation, to get into that area of the heart and make the ablations there. Medications that we often have patients on, or at least try medications before this procedure, would be beta blockers and sometimes antiarrhythmics as well. But if they're still having refractory episodes, they're symptomatic or having adverse effects related to the medications, then we can consider doing a idiopathic VT ablation. But really, in the scheme of it, it's kind of like an SVT ablation in terms of complexity. We're just going into the ventricle instead of the atria. So, because all these kind of fall into the same category in terms of what's involved in the procedure, we're just making, in the scheme of things, not very many burns in a single area of the heart. So access sites are most often bilateral. So we'll have, because we have these multiple mapping catheters, we don't want to put 5 different sheaths in one vein. We'll do 3 and 2 or 2 and 2. And again, we're going into the femoral veins, not the femoral artery. So that's why our growing precautions are a lot different than heart catheterization patients, because we're going into a low pressure blood vessel, and those patients tend to do very well. And so the main thing to look at is, okay, are they having excessive bleeding? Are they developing a hematoma there? Because there is a chance that there's inadvertent damage to the artery, which is right next to the vein, or just there wasn't complete hemostasis achieved after. So if a patient's having kind of bleeding on their gauze, especially after they get up, our recommendation is just to hold direct pressure for 15 minutes and then restart their kind of bed rest precautions and let that block. Good idea to check pulses, but again, we're not going into the artery, so it's unlikely that we've done damage to the femoral artery. Medications, usually with these we'll probably stop their antiarrhythmic because we're pretty confident that we got rid of the source, and that's part of the reason we're doing the ablation, is to get them off of antiarrhythmic medications. Typical atrial flutter patients will still continue anticoagulation at least until the follow-up visit. And oftentimes, if patient's otherwise healthy, we'll just put them on an aspirin after these ablations, just to minimize the risk of thrombus development where we made our lesions in the heart. The activity limitations we give them is I just tell the patients not to do anything strenuous for about a week, and so minimizing any heavy lifting, kicking, walking is just fine, but just anything to try and minimize a lot of range of motion at the hips. And so, and if they have any kind of like worsening pain, hematoma, swelling in the area, then I have them either call us or go to the emergency department for evaluation. Typically, if that was the case, we would just do an ultrasound to take a look at the femoral veins, but also the femoral artery, and make sure that there's not evidence of a pseudoaneurysm. Bandages, I'll usually have them, typically when you guys see me in the morning, I'll talk to the patient and say, okay, the bandages, keep those on. Tomorrow you can take a shower, and then after the shower you can take them off. If the area irritates them, they can just put Band-Aids over those sites, but they heal up pretty quickly. We don't use any kind of a hemostatic closure device on those, because again, it's just venous access. Any questions about our SVT ablations? All right. So the next type of ablation, the one that we're doing, we probably do 2 or 3 of these a week, is the atrial fibrillation ablation. This is kind of our biggest, in a sense, biggest and most common type of ablation. So an atrial fibrillation ablation is trying to help control a patient's atrial fibrillation, or reduce their burden. It's not curative. There's nothing we do regarding atrial fibrillation that I would call curative. We're doing things to kind of help treat their atrial fibrillation. So the main thing when someone has atrial fibrillation, what can actually cause death, disability, is stroke. And so that's why we have to really make sure our patients with atrial fibrillation are anticoagulated if indicated. Everything else we do is to help them feel better. And that's why we'll try antiarrhythmics. If they've failed that, then we can consider, okay, maybe an ablation can help limit their atrial fibrillation. In some patients, it has long-term efficacy. We do an ablation, and they never have recurrence again. But again, we're looking at years here. It's hard because these procedures have only really been around for the last 10 years or so, and they're continuing to get better and better and more sophisticated. So I think that'll start to change, but again, it's not a cure. So a patient who has recurrence of atrial fibrillation, I don't say this is a failed ablation. I'd say, well, this is something that probably at some point in time may happen again. That's why I'm really big on lifestyle management stuff for these patients to minimize the risk of having recurrences of atrial fibrillation. We always keep our patients anticoagulated indefinitely following atrial fibrillation ablations, because I don't want to find out a patient had a recurrence because they came in with a stroke. I want to hear out because they told me about their symptoms, and that's something I discuss with my patients. That's not the case for all electrophysiologists. Some electrophysiologists are so confident in their procedures that they say, okay, go off the anticoagulation, you're never going to have it again. I don't quite agree with that strategy. So with the PVI, there's a few steps that are involved in the procedure. The first thing we do is a transesophageal echo, because we want to ensure that they don't have any blood clots sitting inside of their left atrium before we get in there and start manipulating catheters. So that's our kind of first step. We'll bring them into the cath lab, get them sedated, and take a look at the atria, and then if that's negative, then we proceed with the ablation. So with the ablation, what we do is gain bilateral femoral venous access. We have 3 sheaths in the right side, and then 3 sheaths in the left side. Most of those are for the ablation catheters, but we also have one that's an intracardiac echocardiogram. So what this is, it's an echocardiogram probe that's basically on the end of a catheter. That gives us a nice view of the atrial septum. It's not enough to rule out if they have a thrombus or not, so that's why we still have to do the transesophageal echo. But it gives us a good view at the atrial septum for when we do our transeptal puncture. So the kind of steps in the process is, once we've got all of our sheaths in place, the first thing we do is map out the right atrium, and so draw the electrical map there, identify if there's any significant structural abnormalities, get all of our catheters in place. And then the next thing is, okay, we need to get into the left atrium, because this is where the ablation happens. Again, we don't want to do it from the arterial side, because that's going to increase risk of bleeding and everything. So to get over there, we have a catheter that has a kind of a point on it, but also just a small ability to make a burn. And so that catheter goes into the right atrium and then pushes against the atrial septum. We look for that on the intracardiac echocardiogram to ensure, okay, yep, it's pushing on the center of the atrial septum, and then make a small burn there and then pass through. Once we're over there, we ensure that we're in the left atrium by injecting a tiny amount of contrast, but also drawing arterial blood gases from the tip of that catheter to ensure, okay, this is arterial versus venous side. Once that's the case, then we basically pass a sheath up through there. So now we have access from the outside of the body all the way into the left atrium, so that we can move catheters inside of there, change out catheters for ablation catheters. And then we do that a second time, so we have 2 catheters that are now inside of the left atrium. Let's see. So basically the way it looks when the catheters are inside of there, because this ablation is is anatomical. We're not necessarily trying to induce or get rid of something. We're trying to isolate all 4 of the pulmonary veins. The reason being is that the 8 pulmonary veins are where we have blood from the lungs entering the heart. And the problem there is that the atria is a muscular structure, but the pulmonary veins have a different tissue kind of morphology to them. They're not made for conducting electricity. And so what happens with atrial fibrillation is you have electrical depolarization that happens at the atria, moves into the pulmonary veins, fractionates, breaks up, and then enters the heart again. And that's what causes this atrial fibrillation. So the goal of the ablation is, well, we don't want electricity to enter or leave any of the pulmonary veins. And so to do that, we put a catheter that's kind of a lasso, so it's a spiral, inside of each of the pulmonary veins. And we look for any conduction that's happening between the electrodes on that catheter. Then, what Dr. Tal will do is use this ablation catheter and make a series of electrical burns around the outside of that vein until we've shown that there's basically electrical quiet on the catheter that's inside of the vein. And so once we've shown that, okay, it doesn't appear that electricity is happening going from the atria into the vein, then we'll do pacing. So we'll pace from inside of the vein and see if that makes it out. If it doesn't, we'll go the other direction, see if that blocks it. And then we'll give actually adenosine, not so much for the AV node, but the adenosine can actually cause dormant conduction inside of the pulmonary vein to show up. So we'll give adenosine in each of the veins. And if that still shows that there isn't conduction, then they know that they're done with that vein. Move on to the next one, do that same isolation around there. Sometimes patients can have sources that come from other areas. So the atrial appendage surrounding there can also have, cause atrial fibrillation. The vena cava can also cause it. But our typical ablation is we go after the pulmonary veins, at least the first time around. And then if a patient's found to have atrial flutter, do an atrial flutter ablation as well. There's a temperature probe that's used during these procedures. And so this is basically the esophagus. And the reason being is that, again, because the left atrium and the esophagus are right up against each other, any of that heat that we're using to make our ablations can transfer to the esophagus and cause kind of a thermal injury or burn to the esophagus. And so that's why all of our patients are on pantoprazole after the procedures. We want to minimize the risk of developing a thermal injury. Worst case scenario, it's something that's never happened to Dr. Cataldo, but there have been instances of it, especially before they're using temperature probes, is making lesions in the heart and actually causing a fistula between the esophagus and the atrium, which typically doesn't go very well. So that's something that we take really seriously in terms of watching the temperature. That being said, with our ablation, every time we make an ablation, there's also a continuous flush happening, heparinized saline, through the tip of that catheter to minimize the heat transfer, but also just the nature of how the ablation works. You're ablating just in one area, not causing this propagating heat. So that because of that, there ends up being a lot of fluid that's given to these patients during the procedure that, at least at this point in time, isn't documented as part of the I's and O's because they're not using Cerner for all the recording inside of the cath lab. So that goes into a different system that's only available in the cath lab. So it's not uncommon for patients to get 2 liters of fluid during the ablation just directly into the ventricle. And so the I's and O's are usually not accurate. So that's why we kind of have to clinically assess. After the procedure, we will give the patient a dose of Lasix depending on what their fluid balance is. So if a patient's a couple liters up versus what their Foley's outputted, then we'll give 20-30 of Lasix. It's something that I always check for in the patients in the morning and see. Sometimes they'll have to go home on increased Lasix. After our procedure, patients lie flat for 3 hours. Some of the complications that we can run into with the ablations, or really any ablation, would be pericarditis. And so by making these burns inside of the heart, that heat can irritate the pericardium, and they can get kind of typical pericarditis symptoms. And so the chest pain that's worst lying flat, pain with taking a deep breath, and kind of, sometimes a friction rub as well. If that's the case, if I suspect it's pericarditis, I'll give them a dose of, IV Toradol. If that helps resolve it, then I might send them home on just continuous anti-inflammatories. Bigger concern would be development of effusion. And so, again, some of these structures in the heart are very thin, especially the atrial appendage. And so it's possible that there's perforation during the procedure, and now you have development of a pericardial effusion. So a lot of times you guys will see if a patient's persistently hypotensive, they're having a lot of chest discomfort, sometimes we'll get a limited echocardiogram to ensure that there's not the development of a effusion after the procedure. And again, because these patients are anticoagulated, there's an increased risk for that. And pericarditis. And yeah, oftentimes too, I'll get called for a delta change in their H&H, and usually what that's the result of is dilution that's not accounted for based on what our eyes and nose show, and so it's almost always dilutional, because even if they have a pericardial effusion, the amount of blood loss into the pericardium is pretty limited and wouldn't cause that big of a change. If I am worried about it, though, I might send a patient for a CT just to evaluate the access sites and see if there's any other sources of potential bleeding. Medication-wise, after these procedures, again, we always keep them on their anticoagulation, and usually we'll put them on some kind of an antiarrhythmic. And so it might be the antiarrhythmic they were on before the procedure, or depending on how refractory their atrial arrhythmias were during the procedure, sometimes we'll put them on kind of a course of amiodarone. So amiodarone's the most powerful heart rhythm medication that exists, in part because it's dirty in a sense. It has actions basically in all the Vaughan Williams classifications. So it's a sodium channel blocker, a potassium channel blocker. It has mild beta blocker abilities, and some calcium channel blocker. But either way, it works very well because it has all this, but it also has long-term consequences. And so, the amiodarone, partly because it has like an iodine radical on it, can affect the thyroid, and iodine gets really uptaken by everywhere. So it can affect the skin, it can affect the lungs, and so it's usually kind of a short course medication in most circumstances, but it's a great medication to help keep a patient out of atrial fibrillation following an ablation. So sometimes I'll put them on kind of the our standard oral loading dose, which is 200 milligrams 3 times a day until a set date in 3 weeks, and then once a day until follow-up. I'll see them in follow-up and usually have them have it for 3 months. I'll have them stop it, and then I'll put an event monitor on to see if they're having recurrences off of antiarrhythmic therapy. Once the amiodarone washed out, then we can consider starting something else if we need to. If they were on medications when they came in just for rate control, like metoprolol, diltiazem, digoxin, you will pretty much always stop the digoxin, almost always stop the diltiazem. Beta blocker kind of plus minus. If they have LV dysfunction, they're on an evidence-based beta blocker, we'll continue that, or may sometimes maybe just decrease the dose. Activity restrictions are pretty much the same as our SVT ablations in terms of the groin site. Usually I try and have these patients take it pretty easy. I don't want them getting back into strenuous activity, at least for the first month or two, like competitive stuff, because we really want them to give the best chance of recovering from this ablation. It's not uncommon to have kind of brief recurrences of atrial fibrillation, atrial tachycardia overnight on tele as they're recovering from the ablation. Again, it just takes usually some time for things to quiesce. So the biggest, or kind of the highest risk and probably the most infrequent procedure we do, but is still something that we are doing, is ischemic ventricular tachycardia ablations. And so an ischemic ventricular tachycardia ablation is a patient who has refractory ventricular tachycardia in the setting of structural cardiac disease. So they have a severe dilated cardiomyopathy, or they have an ischemic cardiomyopathy, and they're having continuous ventricular tachycardia that's requiring their ICD to either very frequently pace terminate or cause high voltage therapy to terminate. And no matter what antiarrhythmics we have them on, amiodarone, whatever, they're still having recurrences. And so this is something that we can consider for these patients to try and help limit their burden of device therapy, but has a lot of risk involved because we're doing a procedure on a patient who has significant known structural heart disease, and we need to, by nature, induce ventricular tachycardia to identify where we need to get rid of it. So with this ablation, the idea is that we want to isolate the area of old infarction. So if they had a anterior infarct, we need to figure out what the borders of that infarction are, because that dead tissue is what's causing these reentrant ventricular tachycardias. So with these procedures, we will almost always use cardiac anesthesia. We'll have cardiac surgery at least aware that we're doing this procedure. We'll have an impella in the room, just in the event that these patients decompensate, because they can go pretty quickly if that happens. But again, these are kind of in a sense, an ischemic VT is sometimes a last ditch, if everything else hasn't worked. So what's happening in an ischemic VT ablation is we get into the left ventricle. Usually we start with the transeptal approach and see if we can find the borders of the scar that way. Sometimes though, because we have to do so much manipulation inside of the left ventricle, the pathway that the catheter has to take is so tortuous, because they go from the vein into the right atrium, through the septum, and then down into the ventricle. We're limited in terms of how much the catheter can actually manipulate. So sometimes if the borders of it are very superior, what we'll have to do is actually go in through the aorta retrograde so that we have better catheter control inside of the left ventricle. So sometimes these patients will have had arterial access with the procedure. But again, what we're looking for in here is all this colorful area is kind of dead or poorly conducting tissue. And so we can tell by, we pace, we watch the conduction and say, okay, these areas are slower. This blue means it's kind of the slowest. And so what we'll do is make a series of electrical burns all the way around that scar in the heart to try and prevent conduction in and out of that area of infarction. So with these procedures, again, similar to an atrial fibrillation ablation, we are giving a lot of heparinized saline during the procedure, so that's something to watch out for, especially because these patients have known structural cardiac disease. And so we're watching their fluid balance a lot closer during the procedure. If they have arterial access, it's the same restrictions that are by interventional cardiology when they have a femoral approach for a heart catheterization. Sometimes, a lot of times, well, maybe about 30% of the time, we'll send these patients to CV-ICU if they're, aren't able to extubate them right away, they're having hypotension. We just need kind of ICU care for them, as they recover from the ablation. Sometimes, by inducing the ventricular tachycardia, the patient's blood pressure cannot maintain even for short runs of it. In which case, the decision either has to be made that we can't do this ablation, or by putting an impella in, which allows for, kind of cardiac output without the assistance of the ventricle, can be considered, or especially if we're not able to get their blood pressure back up. We'll almost always continue whatever antiarrhythmic they were on following these procedures. So yeah, that's kind of the big one. And I think we probably only do ischemic VT ablations maybe once every month or two. Some of these patients will basically refer to specialists who just do ventricular tachycardia ablations, down in the valley or sometimes up in Salt Lake. And some of the specialized places have this system that's a magnetically controlled catheter called stereotaxis, which is able to kind of move a catheter with more precision and allow for kind of all, not having to go with an aortic approach, and then also just, have these really kind of firm contact with it. But that's very, very sophisticated equipment and something that we don't have in Northern Arizona, at least not at this time. So again, these will happen, but these patients typically don't go to 2 East, usually to the higher acuity units.
Do you have like an EF threshold? Because there's so much fluid in there.
No, I mean, if a patient has like if their LV is like less than 20%, I mean, then they're considered to be really, really high risk. But there's not really a hard line. I'd say the most common ones that we're doing up here for these patients are people who actually have had kind of improvement of their LV function. And so I'd say most of these ischemic VT ablations are probably patients that have an old infarct. They're continuing to have refractory VT, but they're clinically pretty well compensated. And so their LV is kind of like moderately decreased, order of like 40 to 45, would be a reasonable candidate for one of these because we know that they'll probably be able to sustain it. But sometimes we have patients who come into the ICU, they're having refractory VT, nothing we can do touches it, and we've had to consider doing the VT ablations. Yeah.
So these candidates don't have an ACD?
Well, so they almost always do have an ICD, but the issue is that they're having episodes that are continuing to happen in the ICDs, either having to frequently pace terminate or they're getting high voltage therapy from them. And so that's, these patients, as if they're ischemic VT, they always have an ICD. But the ICD can only do so much sometimes. In terms of scheduling for these procedures, our schedule is such that we have so many outpatient cases that we very seldom have the ability to add on complex cases for patients who are in the hospital. So, sometimes we'll have a patient who's transferred from Winslow or whatever, and we're consulted for an atrial fibrillation ablation. It's like we can't just add an atrial fibrillation ablation on because it's a 5-hour procedure. And so it's just something to be aware of, is that some procedures like a SVT ablation or a flutter ablation, we can sometimes add on, but it's all dependent on our availability. But atrial fibrillation ablations we almost never do as a inpatient. It's usually we try and control them with something, maybe amiodarone, and bring them back in a month or two for an atrial fibrillation ablation. Any questions ablation-wise, post procedure stuff? All right. So the next thing I'll just go through real briefly is just a review on our sotalol and Ticasin protocols, why we use these medications, and just the monitoring and what the differences are, why they're different. First one is sotalol. Sotalol is probably the most common one that we use in comparison to Ticasin. Sotalol is a pretty effective antiarrhythmic medication. What it does is it blocks at potassium channels, but it's also a nonspecific beta blocker. And so those effects together can be pretty effective in controlling atrial fibrillation. The concern, though, is that when you're blocking potassium channels, you're also going to risk QT prolongation because the repolarization is dependent on potassium channels. And so you kind of have to find this fine line of how could I control their atrial fibrillation, but also not cause excessive QT prolongation. So with sotalol, our practice is we always bring the patients in and monitor them as they get to a loading state. And so that's 6 doses. And sotalol can be effective in treatment of atrial fibrillation, but can also be effective in ventricular tachycardia as well. So depending on the patient, sometimes we'll be using it for PVC suppression or VT suppression. This medication is a great option for patients who have known coronary disease. We can't give simple antiarrhythmics like flecainide or propafenone if a patient has a history of an old infarction. So this is kind of a common one if they have any structural disease. If they have severe LV dysfunction, though, less than 25-30%, you can actually worsen that with giving them a high dose of a beta blocker. So those patients we'd have to use dofetilide for, but typically most patients can tolerate the sotalol. Things that would cause intolerance to sotalol would be excessive bradycardia, and because it's a non-selective beta antagonist, it can actually worsen reactive airway disease. So if a patient has bad asthma, bad COPD, you can actually worsen that by giving them sotalol versus because it's basically going to have an opposite effect of what albuterol would do. And risk of prolongation is possible in sotalol. Torsades is considered less likely in comparison to Ticasin. And so our monitoring for that, therefore, is we have the patients monitored in 3 South or higher for this medication. It pretty much always ends up 3 South. Very rarely do they end up in step down for it. But the main things we do kind of a baseline for them is we want to see what their baseline electrolytes are. We want the potassium to be greater than 4, magnesium greater than 2, and because it's a renal cleared medication, we want to check their creatinine clearance, and that helps us decide what our starting dose is. So with this medication, we do our EKGs daily, and so we want that EKG done between 7 and 8 a.m. That's for Dr. Cataldo to review to say, okay, QT interval looks stable, and usually we're basing it off of what their baseline EKG was. We also take into account, do they have a wide QRS duration, because that's going to affect what their true QT interval is. And then we basically authorize both daily doses. So QT interval looks good, electrolytes look good in the morning, they're on 120, we'll say continue that, or we might up titrate or decrease the dose depending on what we see. And sometimes we'll see bradycardia in these patients. Typically our threshold to stop it based on bradycardia is pretty high, because we're trying to treat atrial fibrillation. So if their rate's in the 40s while they're sleeping, 50s while awake, but they're otherwise feeling okay, they're feeling better than they would be in atrial fibrillation. So we'll oftentimes say, okay, that's acceptable. We'll see how they do in the real world. Sometimes we'll have to discontinue or change to something as an outpatient. So the other medication that we use that's a little complex is the dofetilide or Ticasin. This is a potassium channel specific medication, so it doesn't have a beta blocker component. So the patients that we choose for Ticasin are patients that either we've tried sotalol, they weren't able to tolerate due to excessive bradycardia, or they have COPD, asthma, or they have severe LV dysfunction that we can't put them safely on sotalol for. And so, again, this medication can work in both atrial and ventricular arrhythmias, but it does carry a higher risk of QT prolongation resulting in torsades. So because of the risk is higher, what we do with this medication is we want our EKGs performed at the kind of peak concentration. So that's 2 hours following each dose. And so our scheduled dosing for this is 9 o'clock in the morning, 9 o'clock at night, and then we want an EKG done 2 hours after the dose. So if the dose is delivered late at 9:30, we would want that EKG done at 11:30, not 11. So with those EKGs, basically the night EKG, don't need to call the provider even if the QT is prolonged, because they'll be reviewed by Dr. Cataldo or myself in the morning to decide, okay, we're good to give them the 9 o'clock dose, or we're going to adjust the dose. We do have standing orders for magnesium and potassium replacement and step down for this medication, and any kind of wide complex tachycardia that warrants a provider call, because it could be torsades, in which case we want to give them magnesium. And we also are really careful about what medications could interact, and so we'll take a look through their med list. Some things that wouldn't normally be classified as QT prolonging agents in combination with dofetilide can, and so like Benadryl, if patients take Benadryl for sleep, we'll stop that while they're here. Antidepressants are kind of tough because they're hard medications to just stop. So sometimes, depending on what their baseline QT is, we'll keep them on it and see how they do. But if they have QT prolongation, we might have to talk to their psych provider to see if there's alternative agent that they can use to help minimize that QT prolongation risk. And then, after the morning dose, that EKG is done in the afternoon. Typically, I'll end up reviewing that from the office and putting a communication order in. If you haven't seen anything by 5 o'clock, it's good. Just give me a call and I can take a look and authorize the dose for the nighttime. So QT interval measurement, unfortunately, there's limitations really in any EKG machine. Ours tend to have a lot of artifact, and there's inherent flaws in the algorithm that they use for measuring the QT interval. And so the printed QT interval is usually not accurate, and so that's why it needs to be reviewed by a cardiology provider to say, okay, this is what it's actually measured out at, this is what it is in comparison. And telemetry, can get QT intervals, but they're only looking at certain leads or inferred leads, and so that's why we need an actual printed EKG to really decide what their QT interval is. And again, kind of a just summary of how to measure the QT interval. We're looking for the first downslope of the Q wave to the end of the T wave, kind of where the T wave flattens out. And the QT interval that you measure is, you have to make a calculation to how does it compare to the rate. And so if the rate is 60, the QT and the QT corrected are the same. But if the rate is higher, then the actual the corrected QT interval is actually going to be greater than that rate. And so there's a calculation that we do. We use the Bazett formula, which is the QT over the milliseconds of the cycle length, and that gives us our value. So we always make that adjustment. That's what we're comparing, is QT corrected to QT corrected, not QT to QT, because again, it's rate dependent. So it's really important when we get these EKGs to have as clear of tracings as possible, so we really know where the off slope of that T wave is. Up here, because our climate's so dry, it's really important to keep those EKG electrodes in a sealed Ziploc bag, because if any air and those start to dry out, air doesn't conduct electricity well, so that's where we get a lot of this baseline artifact. And also doing good skin prep, especially because we have these patients in the hospital for 6 doses, they're on continuous telemetry, they're not showering, so a lot of oil gets on there. So it's really important to get good skin prep, using electrodes that are fresh to get as good of an EKG tracing as possible, because we're really trying to get milliseconds out of that. So and then also on the printed EKGs, this is something we unfortunately can't change. If you get the printed copy, it'll say QT/QTC, and it'll give 2 numbers. And then then at the bottom it'll say QTCB, and it'll give you a different number. The QTCB is the number that we're using. When it gets uploaded to the computer, it says QTC, and it uses the QTCB. But the printed copy, that the formula it defaults to is the Forelli, which is a different equation that they use in Europe and we don't use here in the United States. And so that's why there's a discrepancy between what's on the printed copy and what gets uploaded to the computer in terms of what the reported is. But again, it all comes down to what our interpretation is to guide dosing on it. The tricky thing actually with dofetilide too is insurance coverage for it can be kind of variable. The pharmacies never stock it, and the patients are always leaving like near the weekend. And so I've been trying to minimize that by sending prescriptions in early on, but there's always ends up being issues with the pharmacy not having it. They want to know the final dose. We don't know the final dose until we're done loading it. It's capsules, we can't split them, so it's always kind of a nightmare, and I'm trying to figure out the best way to manage that. But that's something that sometimes the pharmacy will be calling, trying to figure that out on your end. So just be aware. Any questions? Crash course in electrophysiology. But yeah, I mean that's what we do. It's a good specialty. Dr. Cataldo is very active in it, and I think it's a good service for the hospital. But it can be complex at times, and I don't expect anybody to have an understanding of this because it's nothing that you're not ever taught. I wasn't taught this in school. It's not part of normal nursing education or any provider education. And that's why I'm always happy to answer questions about it and clarify things, because it can get a little funky sometimes. So, all right. Well, thanks for staying awake, and I will send the lecture slides to somebody to put somewhere if you guys want them for reference, because a lot of this stuff is pretty wordy, but it kind of goes through a lot of, I'd like it to be some kind of a reference. And yeah, and I think Mike Skaggs is coming over at some point in time. I'm not sure what's next on the itinerary, so cool. All right, thanks guys. I'll see you out there.